Primary surgery for patients that present with stage 4 disease has been a controversial issue as of recent. You know, the traditional approach was to defer surgery for these patients because obviously the breast cancer has already metastasized beyond the breast and axillary nodes, so it was very unlikely that we'll improve the outcome of these patients by removing their breast or the tumor surgically. And we would reserve surgery for these patients for those that have imminent excoriation of the skin or bleeding or ulceration or threat for infection. In other words, what we used to call like toilet mastectomy, so to provide some local control just so they don't get symptoms. However, several retrospective studies that compare patients that have surgery in the face of metastatic disease versus those that don't have shown that those that have surgery do better. But inherent to this analysis is a bias, which is that patients that end up having surgery tend to have minimal metastatic disease, and those that don't usually have a lot more disease. Despite of controlling for this type of bias, most of the studies have shown a significant benefit for patients that have surgery first, and I suspect there is some inherent bias remaining. Obviously, the only way to know for sure is to do a prospective randomized trial where patients will be randomized to surgery or not if they present with stage 4 disease. And such trial is now ongoing from ECOG. It's ECOG 2108, which unfortunately is accruing slowly, so whether it will be completed or not remains to be seen. But nevertheless, this is the only trial that prospectively can address whether we do need to electively do surgery for these patients or to just leave it and do it only if they have local problems.